All right, that takes us to Article 8, Optimizing EKG Interpretation in STEMI. So this is, first author is Ivan Rokos, who's a kid who trained at our place when I was program director and who's gone on to do an academic career. He's really worked hard on sort of getting the STEMI receiving centers and sort of working to improve our system in that regard. So it's always nice to see your graduates out there doing good work.
Alma Matou's on this paper as well.
Alma Matou and some cardiologists as well from Di's place.
Yep.
All right, so before we even get into the paper, there's this ongoing friction about this whole STEMI thing and STEMI receiving centers. If you're a STEMI receiving center, the question is, should you have this done from the field by the EKG that exists from the paramedics where it says star, 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 acute MI, or should there be another level of filtration for it? Activating the cath lab could be a big thing if people got to come into the hospital, could be expensive, and there's this desire for it to be done only on people who need it. Now, some of that's obviously going to have some friction. So this paper is about sort of, let's get it out there and do the best we can so that we activate when on the right patients as often as possible. Now, would the cardiologists like this sort of false activation rate to be 0%? They would. It's never going to get there.
Happen.
So let's dive in and see what we got. And this is Ivan's attempt to sort of get us on the right page and sort of bring our level up and focus us in on some of the key EKG features. So EPs are predominantly involved in making the decision. 2004, American College of Cardiology, American Heart, suggested a EKG criteria for prompt, immediate angiography, and new EKG findings have come out since then. So new findings change, well, I should say new EKG findings have been recognized and promulgated since then. I don't think the EKG findings themselves are new. They just have had new attention applied to them. And new findings change which patients may need PCI, so that's been a moving target as well. So the goals these authors have set out is help you do better with your EKG, know some of the newer changes, and there we go. So obviously this is sort of a team game, right? There's a pre-hospital component in many cases, there's the ED component, and then the cardiology and cath lab component. So we got to work well. Yes, there may be frictions, but teamwork is going to be essential. EKG analysis is a fundamental aspect to this, and high-risk findings consistent with acute ischemia continue to be missed, and mimics continue to result in false activation. So they're both sides of the thing we could get better at, no question about it. This is sort of an efficiency challenge, and we need to quickly differentiate true STEMI patients from the large group of undifferentiated chest pain patients so that we can make this work. Time sensitive. And everyone's measuring it. So your center, if you fall out, if you're not getting it done, then you won't be a STEMI receiving center. The authors propose an update of the 2004 criteria and determine the best use of cath lab. That's what they want to talk about. And they propose activation for higher specificity classic STEMI patients, specific STEMI equivalents where they have other EKG findings, and then the post-cardiac arrest patient is also going to get dragged into this, which was a real issue at our place, getting the cardiologist to take some of them to the cath lab.
Too.
But they're doing it now. So we're all sort of jostling for the right place on this, and so this paper wades into it. And they're going to define appropriate and inappropriate cath activation. So there we go. So 3 questions that are going to be answered determining cath lab activation are, and here is what they are. 1, are the ST segments consistent with acute STEMI or a STEMI equivalent? Obviously, if they are and the story is right, then you're gone. Have chronic ST segment elevations not representative of acute MI been excluded? In other words, maybe you shouldn't have activated. And is the patient a reasonable candidate for reperfusion? Don't get all the wheels going if this is not a person or a person who has too many comorbidities or other problems to make it them a reasonable candidate. You know, the cardiologists come down for some 95-year-old who's, you know, blind, deaf, DNR, and has 3 organs failing. You're not exactly going to go to cath lab with that. All right, so what's the classic definition in terms of STEMI? It's greater than 1 millimeter of ST elevation in 2 adjacent leads in a vascular distribution. You know, bioelectric principle is that all leads are bipolar, so you're gonna want to see reciprocal issues, and that's been ignored by this initial criteria, and so we're going to look at doing better.
Which is interesting. That wasn't in there at all.
And then we're going to talk about the true STEMI equivalence, which is a left bundle branch block with some of the Scarbosa criteria. And all the Scarbosa criteria don't perform equally well, and this paper is going to talk about that. Identifying posterior MIs,
Yeah, which wasn't part of it at all in the
Wasn't
beginning.
before, and brings up the whole issue of looking at the electrically silent parts of the heart with V7, V8, and V9. And then acute left main occlusions, and there are, by the way, back to the V7, V8, V9, there are people who've said, why aren't we doing 15-lead EKGs with that on everyone? Or the new technology that's coming where you just wrap a strap around that gives you, 360 degrees in the horizontal plane where you can then pick to print the ones with the most ST deviation. So acute left main occlusion, we're going to look at that, and then the De Winter ST wave complex, which I have to acknowledge. Thank you very much, Ivan. When I read this, I was like, De Winter? Yeah, it's December. Yeah. Of course it's De Winter. But I was like, what's him talking about with De Winter? So I learned something there. And
our fellow brought this up, so I have to give him credit. I had never heard of it either.
All right, so what are the issues when you inappropriately start the cath lab wheels rolling? There's a lot of people and personnel involved. It's expensive. There's implications for patient safety. There's work, sleep, life issues for the cath lab staff. My heart goes out to them. The rates of unnecessary cath lab activation are pretty high in some studies. Some of the initial studies in Los Angeles found rates above a quarter.
Yeah,
and so the need to refine this, which is why some of the people from LA, your cardiologist and Ivan are involved in this, because they're like, God, well, let's hope we can do better. So from pre-hospital care, a lot of false positive activations. And from ED personnel, 5 to 9%.
We still overcall.
Yeah, we're still overcalling. So the question is, what's a reasonable goal? It's never going to be 0%, but maybe less than 5% is a reasonable goal. I still think it's going to be difficult to get there.
I do too, especially if they try to expand the way we're going to talk in this paper.
Right.
It gets a little bit hard.
Right. But I appreciate the attempt, and certainly refining our abilities to read the EKGs is a worthy exercise. So ideal, appropriate cath lab activation is the patient goes to the lab, they get angiography, and there's something to do.
Yay.
It's not just a diagnostic study. They said, here's the lesion, fix it. So reasonable, appropriate cath lab is they went there, but there wasn't something they could fix, but there was disease. They needed a cabbage. There's a lot of diffuse disease. Or the coronary anatomy wasn't amenable to percutaneous, so they're going to get medical management. Or it was an unavoidable angiogram per the index EKG.
It to the cath
You
lab
had
the
to
way
take it. Or there was no PPCI target lesion identified, but the cardiac markers became elevated, so it's pretty clear it was a cardiac event. So those are reasonable, appropriate cath lab, even though we didn't get the biggest bang for the cath lab because we weren't able to do something with it. It was more diagnostic than therapeutic.
Yeah, there's a couple more too.
Continuing the list, before angiography, true STEMI per index EKG dies suddenly.
That sort of the trump card.
Yeah, I guess it was an allergy. And the other categories are after return of spontaneous circulation following a witnessed out-of-hospital cardiac arrest. Remember, we always talk about the two tribes. There's the UCAs and the INCAs. The INCAs are the in-hospital cardiac arrests, and the UCAs are the out-of-hospital cardiac arrests. And nowadays, there's a bigger trend to try and take an UCA where the story sounds like a cardiac event with good bystander stuff going on.
Hopefully, rhythm they can do something
with return of spontaneous circulation, with or without EKG criteria to the cath lab. We're going to look at that.
Yeah.
So, what's an inappropriate cath lab activation? And I'm sure the cardiologists who are involved in the paper said, let's be clear about what that is. And that's no angiography is performed. Either the cath lab activation is canceled or they don't go. Now, you have to be careful about that because we know the cardiologist's behavior on weekends and holidays. We have the paper that says your MI outcomes will be worse. So we have to say no angiography performed, and that wasn't because it was a Friday night or a weekend or a holiday. Angiography without a target lesion identified and normal markers. And then advanced comorbidity, the patient's not appropriate. All right. So now we get sort of into the meat. Can we do better on these EKGs? Can we narrow it down so that the chances that when they go to the lab there's something to do or that it's an appropriate case? And so here's we're going to get to some sort of new things, new proposals. Anterior, when you're looking at this for a STEMI, if you wanted to maximize your diagnostic specificity, right? Now, we in some ways want sensitivity too, so specificity isn't the only goal.
The cath lab wants the specificity. We want to make sure we pick them up as well.
We want the sensitivity. Anyway, so ST elevation greater than 1 millimeter in two contiguous leads, V1 through V4, And the diagnostic specificity will be improved if the ST elevation is greater than 2 in men and greater than 1.5
Right, so
in women.
they're higher.
So go a little more.
Right, not just the 1 millimeter.
Not just the one, push them up.
And
Reciprocal changes are present, and most of us have been looking for reciprocal changes for some time, and we know that it improves diagnostic specificity. This wants to emphasize it a little bit more, that you ought to always be looking. So, for example, you won't get burned by a benign early repole case if you're looking for reciprocal changes, because they won't be there.
They shouldn't
in those.
be there.
So we have some EKGs here, and this shows obviously
That's
big time,
more than a millimeter.
big time ST elevation, but it
some
also
reciprocal
shows
changes.
reciprocal changes in 3 and F, little ST sagging. So
this one is
would,
more likely to need true cath activation than somebody who has just a
and
little
throw in
bit.
some PVCs just for good luck.
Just for good luck. Yeah.
So how else can we maximize the diagnostic specificity for classic STEMI? If we're talking about inferior MIs, ST elevation of greater than 1 millimeter in 2 contiguous leads, 2, 3, or F, and specificity is increased if reciprocal changes are present. So again, now we're harping on the reciprocal changes, and here we see a big time ST elevation in 2, 3, and F.
Right. Again, this is more is better, although this one still didn't say that you needed to go 2 or 1.5 like the anterior does, because because the voltages are relatively smaller in these leads. You don't need that much difference in the ST elevation.
However, the reciprocal changes are what
helpful.
they want to focus on here, and you see them in 1 and AVL, and you see them as well in V1 and V2 and probably V3. So you got it. You're there. That would increase your specificity. Maximizing the diagnostic specificity for a classic STEMI laterally, if you want to talk about lateral MIs, ST elevation greater than 1 in 2 contiguous leads, 1 L, V5, or 6, and again, looking for reciprocal changes, and here we go again, looking at the reciprocal changes here, and here they're seen inferiorly. So, what's the goal here? The goal for improving the EKG interpretation strategies. We're going to look at a few strategies.
Yeah, they kind of lay out several strategies.
Strategy 1, and these are where the questions are likely to lie. What's strategy 1? Consider increasing the STEMI threshold in V2 and V3 to 2 millimeters for men and 1.5 for women. And the American Heart suggests using 2.5 millimeters in men under age of 40. Okay, so higher. Okay. All right, strategy 2, understand the ST elevation mimics. So what are they? Benign early repole, I already mentioned.
And you can divide them by
narrow
and wide.
So on the narrow side, we got Burr. Pericarditis, how do you pick up pericarditis? Remember to look at the PR segments, looking for PR depression, a knuckle in AVR, as well as the non-vascular distribution of ST elevation, usually smaller, and usually without reciprocal changes.
Right.
Left ventricular aneurysm. In other words, if you
had the old EKG.
Oh, get the old EKGs. Is this a persistent? Normal variant male pattern. That's when the EKG is bald, sort of right in this area. And we're talking about some of the voltages, and we're going to talk about that. And then pre-excitation, where you might see both QRS leans and some ST segment deviations. Now, in terms of the wider QRS complex that are STEMI mimics, you got left ventricular hypertrophy, where you start getting flip T waves, and the QRS widens. You know, remember all the different criteria for voltage criteria, ST's Rumholtz and the Scott chest and
lots
Scott
of different
limb,
leads
etc.
you can look at and combinations of leads to
left bundle
determine.
branch. So we're going to talk a little bit about Scarbosa in a moment. Paced rhythms. Don't be fooled by those, because sometimes the pacer spikes are small. Now, you ought to be able to find the pocket with the pacer in it, but sometimes people get fooled. Hyperkalemia shouldn't really fool you. And then finally, we're going to talk about Brugada. All right, strategy 3. Impress yourself that reciprocal changes are really important. Reciprocal changes on the opposite side, 180 degrees out, in those meeting ST elevation criteria will make your call better. And they can be the tiebreaker in cases where it sort of looks like a STEMI, but you're not sure, but there is reciprocal changes. That should hammer it home. The reciprocal changes never occur in normal EKGs or those with the narrow complex ST mimics, STEMI mimics, as I pointed out earlier. And then these reciprocal changes, if they're present In greater than 2 leads, appropriate cath lab activation is almost certain. So reciprocal changes really move you up in terms of whether this cath activation is there.
And more of them.
And if they're absent, think twice. That's really one of the big messages in this paper. Reciprocal changes absent, think twice. Think more about it. Strategy 4, the presence of Q waves. It's hard to Q out if you did an infarct, with the exception of lead 3, where an isolated Q can be normal. Defined as, what is a Q wave? It's more than 40 milliseconds. It's got to be a baby box in duration, excluding lead 3. The presence of Q waves is associated with worse outcomes, for composite outcomes, et cetera. Now, if they're not there, it doesn't mean it's an MI, because they take some time to evolve.
Yes.
But if they are there in the presence of other suggestive findings of an MI, then you really got to pay attention to them. Strategy 5. Computer algorithms may have specificity as high as 90%, but we all see both false positives and false negatives on the computer reads. You can use them as a real-time diagnostic aid, but you got to kind of understand. And in the pre-hospital setting, they lead to increased rates of inappropriate cath activation. That's because what happens is there'll be elevation because the person's moving around the back of the rig, or the truck is bumping around and things like that, which create a lot of noise and baseline variability, which the computer then struggles with and overcalls STEMI.
Right. The cardiologist who's on the paper from Harbor, feels very strongly that you need to read the top of the EKG, and will have a complete meltdown if you haven't read the top of the EKG. And it is worth it. If it says, consider ischemia, then pay attention to that, but then go look at it, because you need to make the decisions based on what you see down below. So.
Well, it is a problem if you don't notice that it says star, acute MI. Yeah. Now, 6, I have to point out that apparently Di could not find a polydactyly picture with 6 figures.
There is a polydactyly.
But you felt it was bad to put up.
I didn't want to put it twice. So.
That's where you get to a sensitive, socially appropriate person and me. I would have put the webbed 6-fingered thing up there.
It's in there earlier. It's not webbed, though. It's just
So
fake.
strategy 6. What's the strategy 6? Immediate wireless transmission and physician interpretation of all pre-hospital EKGs. So some places are doing this, Bluetooth right to the cardiologist.
LA County, we have it now. I'm sure you do it at your joint, too.
And taking it out of the hands of the pre-hospital care personnel. Now, where are they wiring it to? The cardiologist?
No, they're wiring it to our Gmail account.
To the ED. Right. So
to us.
To the ED physicians.
Not to the cardiologist yet.
All right, now we're going to delve into a little bit to left bundle. So left bundle can be a STEMI mimic or a STEMI equivalent. When is it a STEMI mimic? A chronic left bundle patient will almost always have persistent ST elevation greater than 1 millimeter in the anteroseptal and inferior leads. When is it a STEMI equivalent? If it's a presumed new left bundle. We've talked about that. So this
has been considered.
That has been. So now we're going to try and refine this.
Is it really that good?
Because what they're saying is that this is causing us fits. We're getting called for these.
It is. We're all going crazy over this thing. And is it very good?
The newer data suggests that the criteria of new or presumed left bundle has low yield, therefore high rates of inappropriate cath lab activation. Still a difficult place to sit tight on this.
It's still sitting out there in the guidelines. It's just, this one is the hardest one for me.
So this is the hardest one here. So, I know the cardiologists were there, and I know Dr. Rokos was here, and I'm like, don't sell us out, man, because I don't want to be hanging on the fence with one of these. I don't want to be second thought. But still, I got it. We're going to try and do better. And so when they do that, their latest guidelines say that biomarkers will help you in the left bundle. So fine. That means I'm going to be an hour getting the troponin, or 45 minutes. And taking the patient to the cath lab depends on cardiac markers rather than the EKG. I don't know if that's 100% true. This is the toughest slide in the whole paper.
It really is. This one, I'm not sure. First of all, I'm not going to base my whole practice on this by any means yet. But this is what they're proposing. But I'm not so sure.
The next thing is they're saying, well, let us do an echo and see what the anterior wall motion looks like. And I just want to know what the inter-rater reliability is on that for starters. I hear them saying, our cardiologists thoroughly believe that they can tell you exactly where this is with an echo, and I'm not so sure I believe them. But there you go. I have some cynicism with regards to that. Let's just say that. Scientific cynicism. Now, in terms of maximizing the diagnostic specificity of left bundle as a true STEMI equivalent, really, when we talk about the ST, when you look at the Scarbosa criteria, right, there's the ST elevation greater than 5 millimeters. And that's really hard because you don't know where the J point is, where are you measuring it. It's hard to see it. So what they want to do here is what a couple papers have said is remind you that remember, in a left bundle, the T wave should go the opposite direction of the QRS. They should be appropriately discordant. If there is inappropriate concordance in a left bundle, of all the Sgarbossa criteria, that has proven to be the most robust and the highest yield. And so what they're suggesting here is that we, rather than weighing on the ST elevation aspect of Sgarbossa, we really try and adhere more to the T waves. And if they're concordant, and particularly if they have ST elevation, and this is usually out laterally in V5 and V6 where you see that, then you need to start being alarmed. Finally, we're going to talk about the posterior MI, and they talk about getting V7, V8, V9 as one of their proposals. And because you're on the silent side and you're far away and there's more intervening tissue in this aspect of the horizontal plane, you're going to look at ST elevations of greater than or equal to 0.5 millimeters.
It just takes one of these and you're sold on this for life.
Yeah. Oh, absolutely.
Just one. You have prominent R waves in V1, V2, V3, any ST changes in those, flip it around, do it on the back. Just one of these and you're sold.
Or you had an inferior one that only had it in one lead and the second lead was fishy to you. So you is it two contiguous leads inferiorly, and you find out it's posterior inferior when you go to them. And so here we see the idea of looking for a posterior MI, and you can see the ST depressions in V1 and V2, which if you were to turn that around and read it backwards would be look like ST elevations. And so they want to remind you that, and you also see some ST elevations out there in V6. So they want to tell you, all right, think about a posterior MI, and whenever you're thinking that way, consider going out to V7, V8, V9. Now, there's one more category here, the left main coronary occlusion. So if you got a left main out, right, the Widowmaker, it's usually rapidly fatal, hence the name. Some patients have right-sided collaterals and they'll survive to the hospital because they got enough to get around it. EKG findings of greater than 0.5 millimeters of ST elevation in lead AVR.
Tiny.
So, right. And particularly, and this is the important part, particularly when the ST elevation in AVR is greater than it is in V1. All right? And there may be some inferior ST depressions there. So let's look at that EKG, because that's a cath labber. That's a Widowmaker. Oops, sorry. And here you have it. So look at AVR. There's that upward bowing ST elevation that is greater.
Shouldn't be there.
Yeah, that shouldn't be there, which is greater than in V1. And you got some other ST things going on out there laterally that are not nice. And so, and particularly, I would say here in V4 is alarming. So this is one that should get your attention. And AVR, Mel Herbert and others have done these things. Mel did this whole thing on MRAP, for those of you who didn't see it, that is AVR doesn't get no respect, where they talked about all the things that you can do with AVR. All right, De Winter. So I made fun of it earlier, and here we are looking at the De Winter ST wave complex, described in 2008 as indicative of a proximal LAD. So now not left main, now we're looking at proximal LAD. It's this 1 to 3 millimeter upsloping ST depression at the J point, and you're going to see it on this next picture here, those 3 arrows on the right, and it goes with these hyperacute T waves. So this is
they have to be together.
Right, they have to be together. So you got the hyperacute T waves. What's a hyperacute T wave? Too tall, too symmetric. Now, sometimes it's hard to know it's hyperacute because you don't have a comparison EKG. But too tall, too symmetric. And then you see that little sort of sneering J point. It's like a sneer down in the corner where it often goes just below the baseline and sweeps in an upsloping ST with a little bit of depression at the J point. See how the J point's a little lower?
I mean, if you look at that,
that's an injury current.
You kind of it just looks funny. You're used to seeing that part up, not down. And not that shape. So it's not something that would really catch your attention hugely, except that you just don't usually see that.
And apparently you can see it into spring too. So it's not seasonal, the De Winter complex. It's an EKG finding of these two things together. So these EKG findings of De Winter are distinctive from hyperacute T waves, although they look very much like them in terms of the shape and tallness of them.
Right.
But there's that J point component. And this shouldn't be confused with Wellens. Now, Wellens...
Which still strikes fear in my heart.
Wellens strikes fear in my heart. And this is sort of the other bullet that I have a little bit of issue with in the articles, is the bottom here that says Wellens, which we know is a high-grade LAD stenosis, that usually does not require emergency angiography.
Yeah, that one, I'd like to see more data behind that one, because that is an opinion of one of the authors of the paper.
So that's an opinion. If you... I mean, it doesn't take you 2 seconds to look at some literature that'll tell you that Wellens does not do well with medical management. And if they didn't do well with medical management and they were in the emergency room for chest pain, then I think you ought to do something about it.
Calling.
So the other thing to know about Wellens is that the Wellens morphology, which we're looking at here, this biphasic thing in DC in V2 and V3, and a little bit in V4 as well here, that happens most when they're pain-free.
Yeah, that's the problem.
So you may see someone who you give nitro to and make them feel better, and now they're pain-free, and then they get this. And I've had a hard time sometimes with our cardiologists because they clearly believe that it doesn't require.
Well, then sometimes I don't know, or sometimes they want to send them home and bring them back and have them done, and that's a big no.
Oh no.
A big no.
Oh no, not happening. All right, now we're to the cardiac arrest. So someone has an out-of-hospital cardiac arrest,
the UCAs.
And up to 50% of out-of-hospital cardiac arrest patients with ROSCE, who they got vitals back, are going to have had an acute coronary event of the cause.
Sense.
Some of the others are going to be head bleeds. Some of the others are going to be big PEs. Some of the others are going to be, AAAs that ruptured. So certain scenarios are increasingly considered appropriate. So they're going to go through some scenarios. This is a little too specific for my liking, but I'll take it. I'll take it. Like I say, I really appreciate the effort to say, let's do better. Let's do the best we can. So I got it. I'm living for it. And ILCOR recommended aggressive post-resuscitative care involving PCI with these. So that's the last ILCOR guideline. So here we go. Couple of studies on this. ProCat was a study that suggested improved outcomes regardless of the post-arrest EKG. So after they don't even have to have a STEMI on the post-arrest EKG. Now, obviously, if they have a STEMI, your yield of going to the cath lab is going to be higher. If they don't have a STEMI, they're still saying take them. Your yield, the number of lesions you're going to find that are going to be fixed are going to be lower. I just don't want these called inappropriate activations. And this paper is saying, no, we won't. We're going to cut you some slack. So let's kind of look at this. Overall, by the way, survival 40% with favorable neurologic outcomes if the shockable first rhythm and therapeutic hypothermia was done. So we're all playing this game. We're doing the whole shebang. All goes together. So now look at the numbers, though, of what did they find when they go. So if they have a STEMI EKG, 96% of them have a significant lesion.
And 3/4 get it.
So I just had one of the 4% just recently. We had a guy with STEMI EKG who had clean coronaries and a head bleed. So it happens. So some of them don't have it. And of course, the cardiologist came down and barked at me. Thank you very much for playing. We'll call again next time. In no classic STEMI post-resus, only 58% are going to have a significant lesion.
But that's not an only to me. That's like, wow, 58%.
Okay, no, I get it. I'm speaking now from the cardiology point of view.
I see. So I'll play the ER doctor, you play the cardiologist.
There you go. There you go. Yeah. Anyway, so here you go. So getting these post-UCA patients that you get back where you think they're an MI, that's the key thing. You think it was a coronary event. You think it was a coronary event. So what are the scenarios? So 3 scenarios. Acute STEMI on pre-hospital EKG, eyewitness arrest, ROSCE. There you go. That's pretty straightforward.
And they say activate from the field.
Yep. Scenario 2, bystander witnessed arrest, 911, early chest compressions. You get a shockable rhythm, they get ROSCE, go for it. I'm good with that.
Bystander chest compressions.
Third scenario, bystander witnessed arrest, 911, early chest compressions, same as scenario 2. EMS shockable rhythm and ROSCE, but the EKG not diagnostic of STEMI or STEMI equivalent. So I had one of those recently, also turned out to not be PCI amenable. It was interesting, their post-shock rhythm was a flutter with a rate of 150. And even when we went to rate control that and try and get our handle on that, no ST elevations developed. And so they took the cath. I convinced them finally to take them to cath lab, and there was nothing there. Oh well. Hypothermia is indicated again. So, patient selection, careful EKG interpretation to find the true STEMIs. That's what we're talking about here. And those that are STEMI equivalents, we talked about some of those. Determine if the patient is an appropriate candidate for cath lab. Don't send dead people there or bad candidates. Post-resus patients, we've got a couple of scenarios we just went through. Sounds good. So here's our summary. And I really appreciate the work done on this, although I think the 5% goal is going to be hard to get to. It's going to be
tough.
It's going to be hard to get to. So decisions regarding cath lab activation are time-sensitive and somewhat complicated. They are. Requires nuanced EKG interpretation skills, and this paper tries to bring those skills together for an emergency audience, and LSA chose it for just that reason, and I think that's fine. Coordinated system from pre-hospital to the cath lab is required. EKG criteria for appropriate cath lab activation And here they are: classic STEMI, anterior, inferior, and lateral. STEMI equivalents, and here's the list. We went through them all, including the left main occlusion, de Winter, the hyperacute T waves, plus minus on those. 3 out-of-hospital arrest scenarios where they went through, where you look at code status, age, comorbidities, and functional status as well, and patient preferences.
Yep.
So this, like I say, timely. I thought it was good. The EKGs were good. It was a good refresher. I learned something about de Winter that I didn't know. There you go.